Good afternoon and good evening to everyone. Welcome to this week's session of the Global IPC webinar series. As we get going, we'll give everyone a few minutes to join the Zoom link, but grateful to everyone joining today. And this is actually our last session. And today's topic is hand hygiene in the context of COVID-19. A few reminders as we get going. Simultaneous interpretation is available in Arabic, French, Portuguese, Russian, and Spanish by clicking the interpretation button at the bottom of your Zoom menu. And as a reminder, the Arabic translation is available by selecting the German audio channel. If you have any questions about today's topic, or the presentations or infection prevention and control, please use the Q&A function on the bottom of your Zoom menu, and we have a team monitoring that box. If you have any questions about computers or logistics or continuing medical education, please use the chat function, and our Project Echo colleagues will be monitoring the chat. As a reminder, this session is being recorded and your attendance is consent to be recorded. The slides from today and a link to the video recording will be available on the Project Echo website in a few days. The continuing medical education link will be available at the end in links via the chat box. And at the end, we will also tell you about a participant survey we would like everyone to complete and how to access that. I am, as introduction every week, I am Katie Wilson, an epidemiologist with the International Infection Control Program at the US CDC and have been helping to coordinate this webinar series. And with that, I will stop sharing my screen and hand over the mic to Dr. Benedetta Allegranzi from the Global IPC unit. Sorry if I missed the name, I know it's been changing, from the World Health Organization, who will give opening remarks for today's session and get us going. Over to you, Benedetta.
Thank you very much, Katie. Hello, everyone. Good morning, good afternoon, good evening, depending where you are. And really thanks a lot, first of all, to CDC and ECHO colleagues for this webinar series, which I think have been extremely interesting. And it's a pity that today is the last session, but I'm glad that it's on hand hygiene. And also, I really hope that maybe there will be opportunities to revamp this later on. So I think that having hand hygiene as the last, anyway, it's very timely for various reasons, as you may know, and it will be stressed later on by others. There has been a new hand hygiene initiative launched by WHO and UNICEF called Hand Hygiene for All. So we wanted to talk about this, but also as many other topics in infection prevention and control, the current very sad and challenging situations we are living with COVID-19 has given the opportunity to, I think, revisit and also gather much more attention on a number of IPC topics and practices. Hand hygiene is often taken for granted. And I think that these days it got a lot of more attention, but we also, as specialists in the field, are aware that achieving good practices and high compliance is always very challenging. And therefore there is still work to do in understanding how to achieve better behavior and also how to gather more engagement on hand hygiene by different partners and stakeholders. Finally, I think that one of the major assets of this webinar series have been bringing together people from the field, people from many countries. And today we do have many, and it's invaluable how people are having experience in the field can really change the history of practices and also contribute to our thinking, being in organizations where we then try to develop policies and recommendations. So we really appreciate your input. And with this, I would like to hand over to Anthony to start the speaker's session and introducing our speakers and panelists. Thank you.
Okay, thank you, Benedetta. Hi, everyone. My name is Anthony Twyman. I'm one of the IPC consultants for the WHO IPC Hub and Task Force, working with Dr. Benedetta Allegranzi. Happy to be hosting today and happy to get things started by giving a quick introduction of the gracious folks that we have that joined us today. So if I could, Dr. Miriam, could you please introduce yourself?
Good morning or afternoon or evening, everybody. My name is Miriam. I'm an infectious disease physician from the Brazilian Society of Infection Control and Hospital Epidemiology. It's a pleasure to be here.
Thank you so much for joining us. Pam from Malaysia, could you please introduce yourself?
Hi everyone, I'm Yufong Pam from Ministry of Health Malaysia. I'm the Deputy Director of the Sarawak Health Centre and also the liaison officer between Ministry of Health and Hospital University Geneva for the Clean Care is Safer Care initiatives here. Thank you.
Thank you and welcome. Next we have Corey from Barbados. Could you please introduce yourself?
Hi, I'm Corey Ford. I'm from the beautiful island of Barbados, 290,000 people. I'm an infectious disease physician and infection preventionist. It's a pleasure to be here with you.
Thank you for joining us. Next, we have Kathleen from Suriname. Could you please introduce yourself?
Hello, everyone. I'm Kathleen Jari. I'm from Suriname. I'm the manager of at first I'm an infection preventionist and also the manager of the IPC department and also the national focal point at the Ministry of Health.
Thank you. Welcome. Next, we have Melissa. Could you please introduce yourself?
Hi there, nice to be with you all today. My name is Melissa Bingham and I am a nurse and global health specialist. And I'm based in the WHO country office in Timor-Leste, leading and supporting on infection prevention and control for the COVID-19 response.
Welcome, thank you for joining. Next we have David. Could you please introduce yourself?
Hi everyone, I hope you are well. I'm David Simon, the Chief of Water, Sanitation and Hygiene here in UNICEF Venezuela. I'm happy to be here with you all. Thank you.
Welcome, thank you for joining. And next we have Claire. Could you please introduce yourself?
Hello to everyone, I'm Claire Kilpatrick. I've had the privilege of working with Benedetta at WHO since 2008. And I currently also work with water, sanitation and hygiene at WHO and also on infection prevention and control at the WHO Europe office. Thank you.
Thank you and welcome. And last but not least, and I will hand over all screen sharing privileges to our first speaker, Joanna. Joanna, could you please introduce yourself and feel free to kick off thereafter.
Hi everyone, my name's Joanna and I have a water, sanitation and hygiene background and I'm the global coordinator for WHO and UNICEF for the Hand Hygiene for All initiative. It's a real pleasure to be here today, so thank you for the invitation. I will share my screen now. A thumbs up, Anthony, if you can see that okay, please. Thank you. So thank you also to Benedetta and Anthony for the introductory remarks. it sort of makes my life a bit easier in terms of the initial slides. But just to state first, I have no disclosures, and I've inserted here a slide on objectives. The objectives for my presentation really are twofold. Firstly, to orient participants to the work of the Hand Hygiene for All initiative, and with a specific focus today on healthcare facilities, and also to help shine a spotlight on new data published recently by WHO and UNICEF's joint monitoring programme. And just quickly take you through an outline of the presentation just to situate yourselves. So firstly, I'll provide a very brief description of the challenges that we face globally in terms of hand hygiene, and I won't dwell too much on that because I believe you're all very well aware. I'll move on to what the global response has been more recently following COVID-19. So looking here at the sort of an introduction of the Hand Hygiene for All initiative, and then moving on to a summary really of work to date on WASH in healthcare facilities, and in particular looking at WASH Fit and providing some hopefully salient country examples. So just moving quickly then onto the challenge. This slide really focuses on hand hygiene broadly, and it looks at the global level. So we know that hand hygiene is the first defense against COVID-19, and yet we know also that for many people this is really out of reach. And I've added a handful of statistics here extracted from the JMP's database, which are really quite shocking and which you may well be familiar with already. But 40% of the global population do not have a place at home to wash their hands with water and soap, and that's 3 billion people. And these people are mostly concentrated in the poorest countries and most among vulnerable populations. So 75% of this subgroup is at immediate risk of COVID-19 because of a lack of basic hand washing facilities. And just looking briefly at schools before moving on to healthcare facilities, nearly half of all schools globally do not have hand washing facilities with water and soap. So in the context of people of the reopening of schools in just a few months' time, that really is a very shocking statistic. The second piece to flag at the global level is around financing and monitoring. And the data that the information I've presented here is thanks to the WHO-led UN Water GLASS report, so we really have some very good data on this now. So firstly, national policies and plans for hygiene lack resources for full implementation. And we know that less than 1 in 10 of the participating countries that have costed hygiene plans reported having enough financial resources to implement those plans. We also know that hygiene data are limited in availability and quality. So only 18 of the countries that participated reported hygiene budgets, and only 2 external support agencies provided data on aid flows for hygiene. And probably a bit more fundamentally, there is still a lack of an internationally agreed upon definition of hygiene, which really provides challenges for discussions even today with all of you, people who are specialists in this area, but of course provides challenges beyond that in terms of reporting, comparing and setting plans. So very quickly, the third slide on this global level, challenges in particular sort of WASH in healthcare facilities. This is extracted from a recent report that will be launched. I don't think it's online yet, but the data is available and I've put the links there. So 1 in 4 healthcare facilities globally lack basic water. 1 in 10 have no sanitation, and 1 in 3, which is really shocking, lack hand hygiene at points of care. And then services drop by 50% in least developed countries, which is also very shocking. And just to flag here, that there is new data now available so we have 164 countries worth of data, and that's drawing from 473 data sources. You can find your own data, your own country's data by following the link below. And I'd really encourage you to do that if you haven't already. Obviously, these aggregated statistics at the global level mask regional and country disparities quite significantly. And with that in mind, the next slide shines a spotlight on sub-Saharan Africa, which is an area where we do have a lot of data. And you can see here that compared to the global statistics, it's better in terms of availability of hand hygiene materials at points of care. So 3 in 4 healthcare facilities had materials available, but just to flag that less than 1 in 3 had water and soap at toilets, which is obviously a critical moment where we are encouraging people to wash their hands. We also know that soap and water are more common than alcohol-based hand rubs at points of care. And critically, I think that hospitals are much more likely to have hand hygiene at points of care than non-hospitals. And about non-hospital is the sort of the definition provided by the JMP, but essentially that's about 90% is primary healthcare facilities. So just moving now on to sort of the global response. This is the Hand Hygiene for All initiative, which is trying to take a whole of society approach to responding to this challenge that faces us. And it's not sort of plucked out of the ether, as you'll be happy to know. It draws on several different pieces that are already there. This is a movement that has been building for several years and which many of you are an integral part of. But in terms of COVID-19 in particular, it draws on the Strategic Preparedness and Response Plan. It also draws very heavily on the interim recommendation for hand hygiene in public places and healthcare facilities. And in particular for healthcare facilities, it draws on the 2009 first global guideline on hand hygiene in healthcare, and also on the Wash Fit tool, which was published last year. And you can find a document that really clearly articulates what I'm going to try and summarize in just a few minutes on the link that's provided there and is also available in the final slide of this PowerPoint. So key objectives for the Hand Hygiene for All initiative. Firstly, it's to institutionalize hand hygiene into health and wash plans, and also into financing and monitoring plans to reduce the risk of future outbreaks, but also to drive collective action and plans for different settings. So we're not just looking at healthcare facility settings, we're not just looking at schools, and we're not just looking at households. The ambition here really is to take a whole of society approach. And a bit unfortunately for those of us racking our brains as to how to do this, that means everywhere. And so that is a challenge. So we're talking about childcare centres and schools, as well as workplaces, prisons and jails, transport hubs, households, institutions, and places of worship. And of course, the healthcare facility space is an absolutely vital setting. We want to ensure sustained improvements in investments. So we want to identify populations that lack access. We want there to be investments in sustainable infrastructure and practices there. And this has already been seen, and the momentum is building on this. And obviously, just to flag that really everything that we're trying to do is geared towards action at the country level. And I will just, in the next slide, really, I hope helps convey this a bit more clearly. So you can see at the very top there that the idea is to develop country roadmaps that sort of bridge what's happening on the COVID preparedness and response side with mid and long-term development plans, just to make sure that what we're doing is not just a short-term response, but that we are ensuring a sustainable system, so that hand hygiene is a mainstay in government programs across these multiple settings. And underneath you can see that there are these 5 accelerators which have been identified at the global level, all of which are geared towards supporting that country level action and activity. Around financing, to increase both domestic and international investment, but also on data information and monitoring, so that we can monitor and regularly report on global progress of the initiative. And we know that for example, wash and healthcare facilities, that's been a really important piece of the puzzle in recent years, to have that data that we can draw on. Also, in terms of capacity development, to build human capacity to deliver on hand hygiene and more broadly on SDG 6. Then there's this piece around innovation, evidence and learning, and in particular in the context of COVID-19, it's so important for us to be learning sort of horizontally and learning from the experiences of others in different countries and sharing that across sectors and across countries. But there is also a very important role to be played, of course, in curating evidence and providing guidance from that evidence. And finally, it's around multi-stakeholder engagement. So as I've said before, this is across multiple settings. It's a whole of society approach. And this advocacy and networking piece is going to be really important for the success of this initiative, which is one of the reasons why it's so nice to be talking to you all about it today. In terms of how this sort of the structures at the global level, this is led by WHO and UNICEF. Central, obviously, to anything will be the governments at low and middle income country, which are the main focus for the initiative. But also we have global partners at the global level. The number is growing. At the moment, there are 10 partners. And they are really helping us think through how to implement this at the national level and really rallying around support and resources and ideas. And they include the World Bank, the International Federation of the Red Cross, the Global Hand Washing Partnership, the London School of Hygiene and Tropical Medicine, WaterAid, and several others. And then, of course, there's this broad base of supporting stakeholders, which we're really seeking to mobilize around this initiative. And as I flagged at the beginning, this is not, obviously this initiative links to several efforts that have been ongoing for several years. In terms of what's happening in WASH in healthcare facilities, just a very quick dive into that. So this is a very busy slide, but hopefully it shows the trajectory from April 2019, when there was a global baseline report produced, and what we're trying to achieve in 2030, where every user will have quality care and universal WASH. And there was a very important moment in May 2019 with the 72nd World Health Assembly resolution, which you'll all be aware of, I'm sure. And then more recently, with COVID-19, and WASH Fit was launched last week, and there has been sort of a renewed effort and a simplified version for COVID-19, which you'll be able to see in the next slide. And very soon we'll be launching the global report on progress and a number of case studies. I've already flagged some of that data for you in the earlier slides, but please do watch this space for the report that's due to come out soon. And just a quick, to shine a spotlight on WASH Fit in particular. So this is a tool, the report was launched last year, and it's a comprehensive assessment and risk prioritization tool for water, sanitation, waste, and hand hygiene and cleaning, in particular in WASH and healthcare facilities. There are 5 practical steps, which I won't go into because I'm running out of time. And we have developed a simplified, well, the WHO did develop a simplified version of this, which you can access via YouTube, and the link is there for COVID-19. And there are also access to the slides. Essentially, in terms of the indicators, we want to ensure that every facility has a functional team around quality management and quality improvement that operates across sectors, that we have functioning hand hygiene stations at all points of care, in waiting areas, and within 5 meters of the toilets, and also that there is a budget available to cover all associated costs, that staff are appraised of their performance and rewarded where they should be, and that hand hygiene promotional materials are displayed and clearly visible throughout. I'm not going to go into the country examples, I'm afraid, because I have run out of time, but the report is available for you to look at, and I've just collected a few of the top line information in this slide, which you'll have access to as well. Very quickly on the takeaways, and my apologies for going over, really it's just to say that we have a very clear picture, backed by solid data in many places now, of the inadequacies of provision and practice of hand hygiene in healthcare facilities, which I'm sort of preaching to the choir here, and that the Hand Hygiene for All initiative provides a key opportunity to scale up, systematize, and institutionalize hand hygiene. So we all need to continue banging the drum for hand hygiene. And in particular, for this call, the cross-sectoral collaboration is absolutely critical. So WASH on the supply side of things, and IPC on the demand and the behavior change approaches, and that we need to be sharing and learning from each other. So that's it from me, and the references there. So thank you very much.
Oh, thank you, Joanna. That is definitely a lot to fit into just a mere 12 minutes, but I think it's setting the global stage quite nicely and giving us the picture, especially as we delve further into the country examples to follow. So I think that's giving us a nice broad stroke of the landscape, so thank you. Next on the agenda, we will move to the polling questions. So we just have 2 of these for today, and I will throw these up now. So if I can just get a thumbs up, Claire, I see you in front of me. Can you see the poll question on your screen? No. How about now? Perfect. Thank you, Claire. So I will read these out. We encourage everyone to answer, of course. Has there been an increase in leadership commitment at the national or facility level since the recommendations issued by WHO on improving hand hygiene in health facilities and making hand hygiene obligatory in public spaces in light of the COVID-19 pandemic? I'm giving a full minute, so this is, hopefully we'll get a good proportion of answers. And there we go, let's see. All right, an overwhelming yes. I feel like that is a good sign. That means it is on the agenda. I think also sort of supporting what Joanna was just talking about with this global initiative. So I feel like these things are falling in line quite nicely. All right.
Anthony, can you hit the share results button?
Yeah, there it is, everyone. My apologies. I'm clearly still new to technology. So you can see there, yes was 88%, no was 12. So I think this is, for me, this is quite exciting to see. All right, I will stop sharing that one. Okay, I apologize because I hit the wrong thing. I shared, stop. How do I, there we go. You should see question number 2. Claire, can you give me a thumbs up? Thank you. At the time of COVID-19, what initiatives would you think could be useful to support local continuous improvement of hand hygiene behaviors? And you can select multiple options in this answer. We have e-learning tools, social media platforms, institutional targets, systems for personal accountability, and pocket bottles of alcohol-based hand rub. And just while we're waiting, I will encourage again for all questions to please use the chat function, and one of our speakers, panelists, and other colleagues online will be happy to answer them for you. All right, I will end the poll and share. All right, so it seems like for the most part, they're all equally selected, but slightly more with the social media platforms. And I guess it's kind of a pulse of the times, really, the way that we're moving. It's definitely something that we're going to have to head into probably more aggressively. So it's good to see that we're embracing that and catching up with that, but pretty much equal distribution against them all. Thank you, everyone. I will stop sharing this. And on that note, we will now move to the second speaker for today, a good friend and colleague of mine, Claire Kilpatrick. Claire, I turn it over to you.
Thank you very much, Anthony. Thank you everyone again for having me here today. The objectives of this session are to recap on the WHO approach to improving hand hygiene in healthcare since 2009, to outline the global impact in terms of engagement and some survey results, importantly, to review some lessons learned, and to highlight some gaps building on what Joanna has said that can be bridged because of this new Hand Hygiene for All initiative and where we find ourselves with COVID-19. I have no disclosures to declare. Very rapidly, the change model for hand hygiene in healthcare by WHO included awareness raising, mobilising nations, and the use of technical guidelines and tools, formally launched in 2009. At its 10-year anniversary on those web pages, we launched some information, specifically key messages about hand hygiene. So from what we've learned, even in the first 10 years, I urge you all to check the web pages in order to use these messages. They are relevant and will help our journey going forward. I will now tell you information based on these 3 areas about this work, much of which you will know. The WHO Hand Hygiene and Healthcare campaign is called Save Lives, Clean Your Hands. Running for 12 years, aims to bring people together. It has a number of characteristics founded in science, based on engagement, even crowdsourcing. We've reflected on its impact and its reach and adjusted our strategies. And there's a whole load of information about this campaign, not only on the web pages, but also in a publication, a book that was launched in 2017. Resource links will be given at the end. From 2009 onwards, there have been calls to action as part of this campaign. And as you can see here, importantly, from 2014 onwards, the focus of the campaign shifted to be clear that hand hygiene should be embedded as an action in healthcare that will support many other health programs, including antimicrobial resistance, surgery, sepsis, universal health coverage, healthcare for all. And this year, of course, the Year of the Nurse and Midwife had a clear focus, while of course also focused on COVID-19. Just a quick summary of some results from the campaign, and in summary of this slide, just to say that from 2019 results from WHO social media, the Twitter and Facebook posts for the campaign exceeded WHO's goals of reach per message on Facebook or Twitter. So you can see that using that media, building on what Anthony said, is certainly having a reach in a wide range of communities. Additionally, as part of the calls to action from the campaign, but importantly around sustaining improvement, not just awareness, there have been a number of global surveys based on a WHO tool launched in 2010 called the Hand Hygiene Self-Assessment Framework for Use in Healthcare. Surveys in 2011 and 2015 have been reported on in a publication. As you can see, as part of this tool, there are 5 elements to it that are based on system change, training and education, evaluation and feedback, reminders in the workplace or communications, and that safety climate, that culture that supports hand hygiene. In summary, the overall score for 2011 was 335, 2015 with 374. You can see full results here. And some confidential data, not for sharing as yet, but the latest results from the 2019 survey that's just been conducted. And I urge you all to closely review this publication, what comes out. But in summary, the overall score was 365. So we see similar overall scores throughout these surveys over the years, and some change in some of the specific results. But what we will note is that for system change, which is that infrastructure, that commitment to resources, it has continually scored higher among these 5 elements. The institutional safety climate, the culture, is harder often to address. And a caveat around these data, the participants tend to be engaged. They're all people that are part of our campaign, which I'll come on and explain. But they are all people already committed to hand hygiene on the whole, but they come from a wide range of countries. But in comparison to Joanna's data and the presentation from the GMP report, you can understand some of the differences. We do know that there's still issues with infrastructure for hand hygiene, but from this select group, we know that system change and commitment to that has been active. I don't present other data on this today, but as I say, I urge you to read it. And there's some interesting figures comparing World Bank income levels with regards to these results. And importantly, there's a wide range of results, and while not significant for evaluation and feedback, for example, high-income countries don't take the lead over other countries. They do for system change, maybe not unexpected, but they certainly don't in all areas. So we have to acknowledge the work being done in many countries to improve hand hygiene in healthcare. So talking of that committed group as part of the WHO programme and the campaign, one way that we've looked at commitment is about sign up and reach. And many of you will have seen these data. And in fact, on the 5th of May, the Global Annual Hand Hygiene Campaign Day, these are always presented. So 182 countries have facilities that have committed, and nearly 24,000 facilities. But as you can see from the map, we need more to commit. Moving on from that awareness and campaigning and some of the information to learn from that, obviously really critical to this work are the people, engaging people to really be part of it, as I started by saying the ethos of the campaign and those calls to action. So mobilising people in different ways, not just through the campaign, has been at the core. At the start of this programme of work, Ministries of Health and Member States were asked to pledge, and over 140 have done this to date, and you can check that out on our web pages. Powerful statements alongside things like WHA resolutions that allow us to lobby and commit even more to the actual improvement, not just a pledge. And important to, again, engage a range of different people to embed hand hygiene action. I mentioned the campaigns of previous years around AMR and sepsis, but this year, a new poster, a new image that encourages hand hygiene in maternity units. We've also reached out to surgeons and had commitments from them about just how important infection prevention with hand hygiene at the core is important. In the 10th year anniversary, as you can still find on the web pages, statements from ministries, again, 10 years on, talking about just how important a profile for hand hygiene is. And moving through now, we want to talk about how the approach to actual improvement is absolutely critical and how it has to be in a combination of ways. So as a recap of what's available for WHO on hand hygiene healthcare, we have the guidelines, we have the evidence. And although launched in 2019, really clear evidence that we should still acknowledge. We have a toolkit with many tools added to over the years based on that working with countries and people in facilities, all aimed at facilitating moments for hand hygiene at the point of care in all settings. And as a reminder, alcohol hand rub formulation recommended by WHO is available for local production and is actually on the WHO list of essential medicines. So let's talk about improvement in this programme, this approach that's been available, tested, used in many settings. It has to be a combination of steps taken together that will achieve the most success. So not just training, not just monitoring, but changing the system, training and educating, evaluating in real-time feedback, reminders appropriately placed, appropriately targeted, and very importantly, that culture to support hand hygiene. And not only has that model been used for hand hygiene, it's important to know it's been transferred for surgical site infection surveillance, surgical site infection prevention, and also for prevention of CRO. And that's been published. The work around this strategy has been published. Initially, in 2013, following the testing in a range of different countries of different levels, it showed that there was significant increase in hand hygiene compliance across all professional categories when using this approach to support improvement. And more recently, other studies have been published. Additionally, as part of the WHO core components on infection prevention and control, you can see here that the highest number of studies around improvement, that multimodal improvement, came from hand hygiene to inform the evidence of infection prevention and control in healthcare. This is just one example of some patient outcome and quality care studies that have been made available. This from Australia, using the whole approach recommended by WHO over many years, where the government recognised that WHO's call to improving hand hygiene needed to be embedded in their work, shows the increase in compliance in hand hygiene, and they demonstrated a reduction in infection. And moving on to talk about more recent times and the importance of hand hygiene for COVID-19. This year has saw the issue of many new materials, as mentioned already. Clear instruction on hand hygiene as part of the Save Lives, Clean Your Hands campaign in the context of COVID-19. The obligatory note that was launched that urges member states to have, as Joanna said, infrastructure available to allow for hand hygiene in healthcare and public domain. And that all builds on the profile that hand hygiene achieved during the Ebola outbreak and how we've been able to demonstrate more and more detail and evidence of its effectiveness. I importantly want to finish, very close to finishing, on this slide and take a little time for you to read this, to outline this, and encourage you to discuss this in the question and answer section, because we want to move forward together, as Joanna said, on the Hand Hygiene for All initiative, taking account of all we have learned over these years for healthcare, and many others have with work in the community, and look at the gaps, the challenges, and face them together rather than repeat work we have already done. So in the first column, you can see the summary of what I've said about a multimodal approach that works for positive outcome, that a number of tools are available. Using WHO's hand hygiene self-assessment framework can show progress and certainly demonstrates commitment to those who have signed up to this campaign. The WashFit tool gives additional detail, as Joanna has said. They both assist in your improvement journey. Making sure that we present our information, those sound bites, facts and figures on our web pages, use them because it shows that our work on hand hygiene is grounded in evidence. And our many scientific publications on this is important to convince people. But taking it back to the engagement we have had with people and will continue to do, co-creation, creativity, not a top-down approach, but using grounded experiences locally and then collectively is what helps our strategy, helps us to continue to improve. We have a range of opportunities now. Hand hygiene is a quality indicator for healthcare. This is then stated in the IPC core components, but was stated many years ago in a key high-profile patient safety publication. We must focus on this. So besides the campaign evaluation that I've outlined and is here for you to read, we have conducted some of this. We hope to conduct more. The Hand Hygiene Initiative for All isn't just campaigning. It's many things to achieve the improvement we need to see. So let's learn from the campaign, but let's talk about sustainability, not competing for priority for a voice, but embedding hand hygiene in health programs, in communities and healthcare. Let's work together to achieve these resources, a big part of what the Hand Hygiene Initiative for All is all about, and look at how we can accurately evaluate going forward. We have the opportunity now, even that the public are more engaged, so let's take that opportunity. So I want to thank Benedetta in particular, all of the team at WHO, but also Professor Pité and the team at the University of Geneva Hospitals. And to remind everyone online that all of the resources and everything I've shared today can be found and the links will be made available. Thank you.
Nicely done. Thank you, Claire. And I think, you know, to Claire's point, it's about moving together and taking opportunity of what we have to hopefully improve sustainability and practice, right? That's what we want. And I think today we have a few, the next two speakers actually, who will be sharing the third slot. We'll have some commentary from the country. And then again, when we move to the panel discussion with our panelists who can also enlighten us maybe more on how they've achieved some good sustainability and compliance with hand hygiene. Okay, so without further ado, if we can move to our next speaker, David Simon, I'll hand things over to you and we'll kick off. And then Melissa, by all means, come in right after. Thank you.
Thank you, Anthony. Can you hear me, no? Yes, thank you. Thank you, everyone, and thank you for being here. This is a presentation from experience in Venezuela. This is a a presentation worked with all the team, with Ana and with Pedro, that we want really to share with you all the challenge and all the experience that we have been learning here in Venezuela in this kind of context related to hand hygiene strategy, and as well how we are integrating this situation pre-COVID-19 with COVID-19, and always according to IPC and WashFit approach. No? What is very important to understand the situation here is considering the last humanitarian response plan of 2020 share, we have 80% of healthcare settings that have a high risk in terms of water hygiene and sanitation, no? Meaning that 70% of sanitation facilities were not functional before COVID-19, 94% of hand washing points were not functional always before COVID-19, and even in 2019, were reported that almost 80% of the hospital had a lack of water. And this is a context that is from institution, but as well as you can suppose in community level, we have as well this kind of challenges. Meaning that we were really very vulnerable before COVID-19. No? And you all know that COVID-19 did have an impact really strong in public health system in the world. So you can imagine that in this kind of context that we are more vulnerable, the impact is higher. No? And we can say that this is a context where with lack of soap, lack of cleaning products, lack of water, lack of security. No? The kind of security is very, very important. No? And because of socioeconomic crisis related to COVID-19, we have as well a wave of Venezuelan people that migrated from the last year that coming back to their countries. You know that in this region, from 2018, we had a lot of people going to other countries to work, and now they are coming back to Venezuela because in these countries now they don't have the possibility to work. No? And according to the national strategy to prevent COVID-19, what happens is that these people coming back to the country, they need to pass the quarantine in collective shelters where they are tested and where they access to healthcare if it is needed. Then this is a three-burden crisis, not because it's not only COVID-19, because we were working in a protracted crisis related to socioeconomic crisis, but as well this returning people coming to Venezuela is being a new layer in the crisis. No? And each of the crises is increasing the impact of each of the other crises, not meaning that the COVID-19 has a strong impact because of socioeconomic crisis, but as well socioeconomic crisis has more impact because of COVID-19, and returning crisis has more impact because of these people because of COVID-19 crisis. No, I mean the context is as you see is really complicated. No. What is important is from the beginning of crisis, from UNICEF, we thought that it was as well an opportunity to scale up our response in WashFit, IPC, in the healthcare settings. No? And we had a three-pillar approach, meaning, okay, we need to link humanitarian response with something more sustainable, and we are working on capacity building and technical assistance, working with the people in the hospital with IPC and WashFit criteria adapted to COVID-19. We are working in infrastructure for water access. As you see a photo, we are doing boreholes, we are repairing pumps, we are installing electrolytic chlorinators, and doing minor repairs in the sanitation facilities, etc., installation of hand washing points, and as well the distribution of key supplies that are going really critical now to enable the hand washing, the hand hygiene in the healthcare facilities. This is a three-pillar approach that is super important because it's linking immediate impact response to something more sustainable, looking to 2020 and 21. Because as we were seeing in the last presentation, we need to think and to do something before the immediate response. No? Something important to highlight is the high vulnerability context pre-COVID-19 was as well something we were more prepared because we had as well some mechanisms established to be able to scale up the response when COVID-19 arrived. No, hand hygiene is a top priority in the response, top priority, because considering the lack of water, the lack of soap, the lack of wash condition in the healthcare facilities, hand hygiene is a key enabler to reduce the COVID-19 and to reduce and to prevent the other public health risks. No, we were in a context with no soap, no water, and we are putting soap, we are putting water, and alcohol gel really has been a very good option in this kind of context where we have this kind of challenges. No, and we are something important and innovative maybe to share with you all is that we are combining with incentive and training. Super important in this kind of context where salaries are not really good, to find how to motivate people working on hand hygiene, people working on maintenance, operational maintenance, people working on in the hospital, and this is super important to be with them. Sometimes it's about a training, sometimes it's about something like hygiene kits, sometimes it's even about tools that they can use in their daily work. This is super important, no? And linking always hand hygiene with other IPC measures, no? Meaning motivation, meaning infrastructure, meaning availability of cleaning hygiene products. No? This is an overall crisis. This is a pandemic, is a global crisis, no? And we were working under a coverage approach, meaning that we need to reach a lot of healthcare settings, no? We were scaling up from March 2020, where started the pandemic, and now we are in the worst moment. Now we think that we are entering into the peak of the cases, no? And we have been working in more than 100 healthcare facilities settings, and linking a hospital with primary healthcare facilities. What is, I think, is important, linking humanitarian and development nexus, because we think that everything we are doing in a humanitarian approach is going to set up the building blocks for something more sustainable, no? And linking with the protected crisis. As well as you know, considering the mandate of UNICEF, we are linking as well with the mother and child healthcare, which is a priority for us. And in the same hospital that we were working in mother and child healthcare through WOS, working with WOS, as well as the main hospital where we are working with COVID-19. No, there is as well a special situation here that I think is important to share with all of you, is that because of quarantine, we have this kind of collective shelter with people are spending 50, 20 days. In these spaces, there is a public health risk as well, beyond COVID-19, even beyond considering other diseases, no? And there is healthcare brigades that are going to this kind of shelters, doing testing, doing healthcare, and this is super important because hand hygiene need to be part of this kind of healthcare brigades. This is super important because the support that we are providing to the hospital are as well providing support to the other settings where healthcare is being provided. No? And this is as well an approach of supplies and washing points, training, and considering how to do infection prevention and control in these kind of shelters. The technical consideration, maybe to share that we had experienced.
Just going to say we've got a minute or so left, okay?
Thank you. It's almost finished. Technical consideration is only to say that we had experience before COVID-19 that we are increasing now. We had hand washing points in maternal and newborn health rooms, some areas or maternities that has been extended to COVID-19 areas, extended to public areas in the hospital, and extended as well to community priorities or other community approaches like school feeding. No? And it's super important the work empowering IPC committees inside the hospital. This is a key factor to enable the hand hygiene in the hospital, combining mobile and fixed hand washing solutions in the hospital, as you see in the photo, and as well and highlighting the importance of hand hygiene for the personal protection equipment and the use of this equipment. This is super important. Hell alcohol has been a clear enabler of the quick response, and link all of this with the risk communication and community engagement approach. This is an example. No, maybe all of this is undertaken under a collaborative approach with partnership with UNICEF in implementing partners, NGOs, with WOS cluster and health cluster coordination. What is being really critical, and as well supporting both Ministry of Water and Ministry of Health, and as well even we had this kind of engagement or agreement between National Assembly and government. What is the first time we have this kind of agreement from them to support the COVID-19 response, including the hand hygiene. Then thank you very much. As I said, this is a work with my team, with Pedro, with Ana, and super happy to share this experience with you all. And we are ready for questions as well. Thank you.
Excellent. Thank you so much, David. Melissa, we'll jump right into yours.
Thanks, Anthony. David, could I ask you to unshare your screen and then I can share mine? Okay, great. It's lovely to be with you all today. So as previously mentioned, my name is Melissa, and I'm just going to share with you some of the hand hygiene campaign experience that we've done here in Timor-Leste. So just as a start, just to highlight that I have no disclosures to declare, and just quickly to go through some of the objectives of about the next 6 minutes that I have to share with you. I just want to review some of the challenges of being able to obtain proper hand hygiene in Timor-Leste, but also reflect on some of the strengths that were identified in the health system that is actually going to help support some of the activities in strengthening hand hygiene in Timor. And then lastly, just share with you all how the May 5th hand hygiene campaign has actually fostered a bit of improvement around hand hygiene and IPC more broadly. So just to start, to give you all some context about Timor-Leste, it's a fairly new nation. It came into independence in 2002. It's a decentralized health system, and there's 13 municipalities. Within these 13 municipalities, there's 69 community health centers, 313 health posts, 5 referral hospitals, and then 1 larger tertiary hospital. There's about 1,700 health staff that have been reported, and that's from a report that was put out by UNICEF about 2 years ago. So in preparing for the hand hygiene campaign, what we really wanted to do was adapt the campaign and make it specific to the audience. So we took a little bit of time in understanding some of the current challenges and strengths within the health system of Timor to understand exactly what we needed to advocate for when we went through and did the hand hygiene campaign. So the challenges are really not probably that unique, but what we did find was that while there had been loads of training done in IPC, there was actually very minimal training that was done specifically in hand hygiene. Massive lack of water in healthcare facilities. So again, from the same UNICEF report that was put out a few years ago, we knew that 70% of CHCs had little reliability in the water that they had access to. I think there was 30% of these facilities that didn't even have sinks. Lack of consumables like soap and hand rub. And hand rub is actually something that isn't widely available. And so not something that people can rely upon in actually being able to use. There's limited monitoring and auditing So there's really no baseline in understanding even how good hand hygiene compliance actually was. And of course, there's competing priorities and financing and implementation activities that keep hand hygiene from being prominent. And this is for several reasons. Some of it is just there could be a lack of understanding about why hand hygiene is so important, but then also the lack of supplies that are actually available to staff can decrease the internal motivation that people have in order to comply. So that's the bleak picture, but there are some strengths. And in approaching the hand hygiene campaign, we were really insistent on ensuring that people understood that this was a health systems issue. And we wanted to explore and really advocate for the strengths of the health system as a way to kind of seek internal motivation and have potentially start sowing some seeds for behavior modification around hand hygiene. So a few of the strengths were that there's a lot of innovation and a lot of creativity with staff. And, the picture on the left shows a very typical supplementary water station that's commonly used around the world, but there was definitely an understanding and insight into the relevance of having something like this. And so we understood that people were open to creative ideas like this. There's a really strong focus in on teamwork and policies. Policies, of course, it's something that's new in Timor, especially as Timor has only been established for a few decades now. But as an example, there's recently a national quality strategy that is really doing a lot to support infection prevention and control. And so some of what this quality strategy is focusing in on is highlighting the importance of different components around IPC, like monitoring and evaluation. There's indicators that are mentioned within the quality strategy that show that IPC more broadly is a good reflection of quality of care. And so what that has done is highlight some of the leadership component that's involved in emphasizing hand hygiene among health facilities. There's a lot of new innovation that's happening, and there is a lot of partner presence on the ground. And so one of the things that COVID has really helped to highlight is, of course, infection prevention and control, recognizing that hand hygiene is one of the most important issues within IPC. And so partners have really come together to collaborate and build and support both with capacity building, but also financially and with actual infrastructure to improve the water and sanitation and consumable supplies that's needed to foster hand hygiene. And I've already mentioned leadership through the policy, but we were able to have a few of the senior leadership within Timor-Leste really commit to improving hand hygiene and played a big part in the campaign that was put out. This not only included leadership, but this also included some of the more famously recognized leaders within Timor-Leste. And we were able to record and have video presentation. And so when we went and did the hand hygiene campaign, we were able to record this leadership, or we were able to show this leadership and the influence that they were having on decision-making around hand hygiene. So when we did the campaign, yeah.
Just to say, we'll wrap in a minute. Yeah.
Okay, thanks, Anthony. So when the campaign was launched, the goal was to take our time in doing it. And even though the campaign is one day, we actually took about 2 months in order to reach all of Timor-Leste. So we reached all 13 municipalities, and within that had representation from the various referral hospitals and the CHCs. So what we wanted to do is really, again, present the gaps that were presented from some of that early assessment work that we had done, but then also really try to seek motivation through some of the strengths that had been done. So really supporting ideas around innovation, listening to the concerns that they have, giving the campaign materials in a way that they could replicate it in simple instructions. And then again, just really emphasize the fun that you could have around, around educating and supporting your fellow team members around something like hand hygiene campaign. And what I want to emphasize here again is that we really displayed this as a systems issue, and we really tried to acknowledge that good hand hygiene practice is really the responsibility of everybody, not just one person. And it's our responsibility even when there's no soap available or when there's no water available. It's up to us as healthcare workers to create those innovative approaches to sustain good hand hygiene practice. So just in closing, I just want to highlight a few bullets that we have taken not only as an organization, but then also trying to work with the Ministry of Health to continue to foster hand hygiene. So there's been quite a bit of work done on hand hygiene in schools and educating children and teachers in schools, pushing the campaign through the media, again, continuing to seek high-level commitment, both through the leadership, but then also champions and celebrities. Continue with training, emphasize the data and monitoring. And just one point that I do want to make is that the hand hygiene campaign did give us an opportunity to use the WHO self-assessment audit tool. And so now there's a baseline data for understanding what systems, strengths, and gaps actually do exist in Timor-Leste. So that was something that we're able to achieve and hope build some kind of baseline foundation data around hand hygiene. So I'll end with that. And I just want to thank Anthony and the rest of the host and Benedetta for being a part of this webinar. Thank you.
Amazing. Thank you, Melissa. Thank you, David. I think too, just to say quickly, it seemed like even from those two examples, one of the clear messages or themes I got between the two were that there are some building blocks being put in place because of this pandemic that will hopefully lead to sustained change. So, I mean, you know, we always say that we want to learn what we can from an outbreak and have it be, you know, not for nothing. So it's nice to sort of kick off with that and see that it actually, in two different parts of the world, there is an underlying theme that exists there, and maybe even more so in some of the panel discussions we're about to get into. So thank you, David. Thank you, Melissa, for that. Moving on, we will go into our Q&A discussion. I will be co-moderating this with Benedetta, but I will, unfortunately, you have to listen to me for a little bit longer, and I will get us started with our first question to Pam from Ministry of Health in Malaysia. How can hand hygiene be sold as a priority to governments and/or leadership to work with facilities to ensure an adequate budget and supplies for implementation? Pam, over to you.
Thank you for the question. Now, more often than not, those approving the budget and supplies for hand hygiene implementation do have a basic understanding of the manner, but however, these people might have other priorities. So what we need to do in simple words is we need to help them to help us. Because, well, we might be accountable to them. The person approving the budget or the person that wants to support us is also answerable to someone else. So first, we need people to support our agenda, and by that, we need followers. We can do this by understanding what is needed on the ground, by listening and hearing from the voices of the people from the field, and convey these messages to the higher authorities. Now, voices of the patients must also be heard and conveyed to the government and leaders, because if budgeting and priorities are heavily linked to politics, then taxpayers' voices are really crucial. And for us, it's always been useful to specifically know who could support our agenda. And this does not just include ground staff, but higher level healthcare facility managers who are able to put pressure on those who are approving the budget and giving us the priorities. For example, poor hand hygiene can increase the length of stay, can increase workload, and affect their waiting time, affect their key performance indicators. And so on the ground, hospital managers would be one of your supporters in updating hand hygiene budgets if it was to be approved from the national level. And it's also very essential to know, based on my experience, to understand the person who will authorize these things. And when put in writing, specifically who will read it. Now, it doesn't hurt for us to do a little investigation to find out more about the person's background or history, and also their other funding priorities or even their personal interests, which you may want to briefly mention in your request to create a personal connection, which has worked well for us. Now, we should also briefly explain how the budget was created, and if it's involving an ongoing and repeated plan, and if so, how those implementations have fared after the launch. We should ideally include forecasting trends and updates. But it is very important that when we cite trends, we do not compare an apple with an orange. We must choose wisely the data that is available in the internet and choose the facilities which has the most similar infrastructure, working environment, and culture to ours. Because what we want to do is not just to provide the information, but we also want to gain trust and not to be seen as being manipulative or tricking our way in prioritizing our agenda. Now, in Malaysia, people have been very appreciative when we also report and mention unavoidable drawbacks related to the budget and what are our remedial actions. Now, for some, this might be done in closed doors. And while I understand that some people might not like the idea of re-exposing our poor performances, we should always understand that it is vital to be honest, as this type of communication is about gaining trust for a sustained and long-term uninterrupted commitment. And while priorities are gained from leaders and governments, money can still be tight. So it is absolutely necessary to explain how money would be specifically spent. And last but not least, I think this is very important because it's also linked to behavior, is that we need to be persistent and keep trying. And we mustn't be seen as an irritant. For example, we should be consistent with on reminders, say setting it at every 5 working days or whatever time frame that works for you. And we should try to stick to this time frame and don't defer from it, because when we are seen to be consistent, government and leaders are less likely to see us as an irritant, but being committed to the task and therefore able to focus on the request itself. And one last very localized and technical, and I would say a quite innovative method that might work, depending of course on your organization, is using colored paper. Now, this has worked quite well for us. This simple gesture could help us keep to our timeline and agenda. For example, I might send my first budget request or plan strategies using plain white paper. And then for the follow-up, I would use a green colored paper. And then the third follow-up would be an orange colored paper. And so when these documents actually gets to the desk, it would stand out among all the other papers that are sitting on the desk. And when you give them a call, you could say, yeah, I sent you a reminder, it's the green paper, I think you could see that, and that it would somehow get prioritized. So thank you very much.
Thank you, Pam. I actually really like that you ended on that note. That's a nice little personal touch of like standing out, that what is it, like the positive deviant amongst everything where everyone has to notice. That, well put, well articulated, thank you. Moving on, so next is on the theme of behavior change and implementation. I'm gonna start with Miriam, the question with you first, and then we'll move to Kathleen. Drawing on your experience, what have you found to be effective strategies for keeping high compliance with hand hygiene in health settings during and especially after the COVID-19 pandemic? So Miriam, over to you first.
Thank you, Anthony. It's interesting because the social media thing pulled up in the pooling thing. And what we did this year that was different from previous years, additionally to traditional strategies of reminders and auditing and feedback, was the use of social media. So we did this in two ways. First, we challenged our healthcare workers to do videos in an app called TikTok, teaching hand hygiene, donning and doffing, and it became quite popular. We had lots of videos, creative ones, and lots of views and likes. And also by doing the videos, they had to review their knowledge, and also it helped them to retain the knowledge and feel them as a part of the thing. And the second strategy that we used with social media was doing videos focused on patients, showing them critical moments of possible transmission of COVID-19. And we shared the videos on Instagram and Facebook, and we also had lots of views and likes. And so these were new things that we applied this year.
Excellent, thank you. And I should note, actually, Miriam did share some of those resources with us. Although we don't have time for them today to display, we can include them and share them with the other presentations in that as well. So just wanted to echo that. So thank you for that, Miriam. Over to you, Kathleen.
Okay, from our side, reminders have been put in place at all the workplaces in several languages. Also, leaflets has been made, and videos, short videos has also been put on social media and also within the healthcare facilities. The community has been engaged, and also the patient regarding hand hygiene, how to perform it, also at schools. And also continuously training has been done for all facilities, not only the healthcare facilities, but also the other ones. And also information has been shared, how things has been done, who has done what, so that we can data information sharing and also experiences has been also been shared with everyone. So social media has been very important for us at this moment also.
Thank you, Kathleen, for that. I think, yeah, it seems to be a common theme. I think we're all embracing now with social media. And I think maybe for some of us, we've underestimated how it could impact within the healthcare setting. We often see it as maybe a much more community and just social way of interacting, but actually it's so much bigger than that, and maybe more than we've given it credit in the past. So a silver lining of COVID potentially for all of us, a big learning. So thank you very much. So Benedetta, I hand it over to you for the remaining questions.
Thanks a lot, Anthony, and everybody so far. So, yeah, I think it's interesting really to hear how much social media can really catalyze excitement and also commitment and apparently change of practices. On the other hand, being a scientist and being based on science more, I really always call for more robust ways of proving that there is a change in behavior. And I know that this is hard to perform, but also we know that monitoring practices and understanding how they actually happen is one of the ways that actually help in motivating people to improve their behavior if they don't perform well. But I like much more saying that when they see their improvements, this is something really boosting their motivation, their conviction to continue to perform well and to really show their commitment. So this is based upon this consideration. I would like to move to asking a question to Corey Ford, my friend who has been working for long in Barbados. We have interacted many times related to their different situations where hand hygiene has always been at the core, I understand. So, Corey, can I ask you, these days during COVID-19, for instance, many monitoring tools for healthcare facilities and implementation of IPC practices have been developed, including by WHO. And we really know the importance of really assessing the situation. But also, I think that we all know how difficult it is to do this in very hectic times when the workload is very intense during an outbreak. So do you have any advice on how hand hygiene practices can be monitored during these difficult times in a rapid way, in an effective way? Maybe starting from your knowledge and experience with existing tools, can they be adapted, do you think? So this is my main question to you. Thank you.
Thank you so much, Bernadette. Good to see you again. And I think the major point here for me is, look, successful hand hygiene campaign programs during COVID are really critical. And we have to try to use things which are in place. I'll kind of give you an example of what's happened in Barbados and try to pan out in terms of answering your question. So I think we have to use, much as most countries are using in this pandemic, use kind of outbreaks to try to drive change within our systems. And we were kind of faced with that in Barbados at one point when we had a massive outbreak of carbapenem-resistant Klebsiella within a hospital, which subsequently led to development of a really strong, rigid hand hygiene program within hospitals. But I think what was more important, or what's more important within the COVID outbreak, is that countries really should try to drive this from the national level. I think this becomes important, and that filters down really into the hospitals and other institutions and in the wider community. I think budgets are becoming important in terms of this process, and this is one of the things that we did at the facility level, having dedicated budgets towards hand hygiene products and the consumables. But then when we look at in terms of what you're directly asking, we look at evaluation and really how we do monitoring. And really, honestly, we really went back to the basics. So, and I think it does not need to change in terms of COVID in itself. So look at your general basic hand hygiene infrastructure, which I heard many of the speakers talk about. Look to see what you have, how you can improve things. Look at where you can put them within your facilities. There may be new COVID facilities, how you can improve and placement of these infrastructural aspects. But of course, practices become important, and basic standard, going back to the basic standard of observer-based evaluation of your systems, but your observers need to be changed. And there are several WHO models and projects, and as well detailed toolkits, which will help you in that process. But I think the other important part, which people often don't think about in terms of monitoring, would be in terms of healthcare workers and the senior managers. What are their knowledge and perceptions as regards to healthcare associated infections and COVID, and the importance of hand hygiene? So I think that was an important point, aspect that we looked at as well. And obviously the obvious one, right? The elephant in the room, which is consumption of hand hygiene products. Like how are they consumed within your system? And not only how they're consumed, but try to trend that with regards to infections within your facilities, and use that to change behavior while looking at the hand hygiene compliance data. So I think if we use all of those aspects in terms of monitoring becomes important, but we need to link that as well to the IPC aspect in the community. So we need to work, and which we have done in Barbados in the COVID outbreak, work with many non-governmental organizations. I think one of the challenges in low and middle income countries is there's often issues with resources. And I think working with non-governmental organizations like World Health or PAHO, CDC, etc., it becomes important in strengthening your system and linking those aspects as well to establish systems as well. So there, for many low and middle income countries or low resource settings, you can get, the type of advice you can get from international colleagues. But the World Health Organization, in finishing, has, of course, we know hand hygiene self-assessment framework tool, which we have used certainly from the start, from before, and we've used that tool to try to define where we are at various points. So whether we're inadequate, whether we're basic, we're intermediate, and where we're advanced, whether we're advanced or not. And while that type of healthcare facility or national bodies may consider that for an adapting tool for comparison, it was not really the reason why it was made. But I think if we go back to basic strategies and looking at monitoring, we have to look at system change, we have to look at training and education of people within our systems. We have to look at, putting the gentle reminders in the work. This is one thing that has worked with us through COVID-19. We've heard a lot about social media, but I think the simple posters allow healthcare workers to remember what they're supposed to do. And of course, all of this ultimately leads towards the institutional safety climate, which one would want for COVID-19. Thank you.
Okay, thanks a lot. Really a very comprehensive answer. I think it's important that you highlighted in terms of rapid monitoring, the importance of monitoring infrastructure these days, because it is the premise for hand hygiene performance, and also the easiness of monitoring consumption. That is also important of both soap and alcohol-based hand wraps. And then maybe I would say only one thing that I wanted to add to what you said is that perhaps IPC people on the ground could slightly adapt some of the tools to check on compliance, like for instance, checking compliance with good practices during donning and doffing, or insist on specific moments that are particularly relevant, in this case actually for health workers contamination, as moment 3 and 4 and 5. So rather than all moments, because it's more complicated, of course, when you have intense work. Sorry, we could stay here for long and we don't have time. So I would like to move to the very last question, which is addressed to David, a colleague from UNICEF. Again, also bridging back to his presentation, really asking you if you have any recommendation or approach that you would suggest when the situation is really difficult, in absence of access to running water, in particular related to the performance of hand hygiene in a healthcare facility. We have heard from several of our speakers or panelists that this is a real constraint in many countries. So what is your suggestion? Is there any option?
Thank you very much, Benedetta. This is a really challenge. This is a complicated situation that we are facing in all of the world. No, maybe what it happens we have this kind of situation is that we need to think as well about how we are working inside a healthcare setting. No, how we can change some kind of protocols to avoid the situations where we need to have water, no? And maybe this is something about organization as well, how to do different. But now in this crisis, what is being really critical is the possibility to have a gel alcohol for this kind of situation. And even we can work on local production as you have the guidelines for WHO that is helping for this. But I think something important is to see this alternative about gel alcohol, but as well to see and to understand how people are doing to have water in these communities. And this is as well related to behavior change, or at institutional level, community level, but how people are getting water. And this is the way that we need to prioritize that we need to have this water as well in the healthcare settings, no? Maybe with a soap, maybe with a bucket, maybe with a tank, but we need to have even a small provisional and mobile solutions that are going to help to have available water and soap, no? But gel alcohol now is being really a critical product that is helping a lot in the COVID-19 context. As well, there is some healthcare settings where there is no discussion. We need to just to have the water inside, no? And this is why we need to maybe to work in boreholes. We need to work in water tracking. We know that it's not sustainable, but in some cases now in COVID-19, in this situation in main hospital, we need to have this kind of solutions, no? After, for isolated areas as well, other things that we can do is, well, as you know, working with water and chlorine, maybe sometimes if we don't have soap, and even we have even solar production of chlorine. There is alternative, but I think for me something important of not having water and soap in healthcare settings, in isolated areas, is related to the behavior of the institution, of the managers, of the people. And I think the solution starts for having really a risk awareness about that we need to find a solution, and this needs to be a context-adapted solution for each of the situations.
Thanks a lot. Thank you very much for bringing these examples. I would say that obviously overall it's always important to find temporary solutions, but then, as you said, to really advocate for longer term solutions, and especially the WASH element that is so crucial, and it requires high level commitments sometimes really from the government, and so it's really important. Okay, so thanks a lot. I'm conscious of time. We are at the end of the time. I just wanted to wrap up on a couple of things and conclude and hand over back to Katie. So I think this webinar has been super rich. There are so many things that we can say. I think that the speakers highlight mostly very positive aspects, and I'm delighted to hear that there is a lot of new energy around hand hygiene and also tangible improvements. I think that, however, we need to stay also focused on the gaps and use this continuous time, unfortunately, that will stay with us for some time to really continue to improve on aspects that we know are always pitfalls or difficulties in the field of hand hygiene in this case, but IPC in general. I think we saw that even from data available from different surveys, we don't have a homogeneous picture of how much progress has been done over time, over years in the field of hand hygiene. It has been highlighted by many of you, and also through the questions and the chat, that the commitment of the leadership is still maybe the most difficult element to achieve and to be successful with. And on the other hand, the positive experience that many of you have reported, I think really indicate that this is really an essential element for any progress, any implementation, and especially for sustainability. So I think we need to work together to find ways to further engagement, leadership at different levels. One of the ways, in my opinion, is really trying to integrate efforts of different areas. So here we are IPC, WASH, quality experts and specialists, and I think that our agendas really must overlap and really coincide over time so that we can submit to the leadership, for instance, to the government, common plans, common initiatives, so that we don't scatter and jeopardize our efforts by working in vertical ways. And we know that from other outbreaks experiences, we know that we all, each one of us, always run this risk to really work alone and not maximize collaboration. So my final really call is really for looking for integration. These days, IPC, public health, epidemiology specialists are really on spot. I think, however, we need to remember that there are other agendas that are put in a corner at the moment, but they are still very relevant to the efforts we are making to fight this outbreak, such as quality care or essential health services. And so this needs to be integrated. The final point, I think, is also that something that was mentioned by many about risk communication. I think that these days we are successful if we are able to translate in good communication, including social media, but not only, the concepts that we want people to implement right away. And this is a very critical area, which is a specialized area, and we should really have the right competencies working in our teams in order to achieve good results. So before I hand over to Katie, I also would like to highlight one word that was said by Pam in particular, but all of you are witnessing this, which is persistence. I think that Claire and I and many of you over time, over many years, maybe got bored about promoting hand hygiene many times, but I think that we really need to remember that it's critical and that we need to persist on the gaps, because there are still many gaps, and we need really to fight together to have almost a perfect implementation of a multimodal strategy for hand hygiene worldwide. So I hope that we can achieve that all together in different parts of the world. So many thanks once again to CDC and ECHO and to all the speakers and panelists for this webinar, and over to Kate.
Thank you, Benedetta. And yes, agreed. Thank you to our WHO colleagues and our UNICEF colleagues for today's great session. And thanks, as always, to Project ECHO for making these webinars successful and run smoothly. Very quickly, the continuing medical education credit is available via the links in the chat box. And a quick announcement, as we close out this current webinar series, we have a participant survey we would like you to complete. We want to hear from you. This was sent out in this morning's reminder email if you scroll down, but we will also send out a separate email later today with just the links for the survey. This should take you 10 to 15 minutes to complete. It is available in multiple languages and will be open for 1 week to help us as we design future webinars. And with that, we will sign off for now, but hope to see you again soon. And we are planning to do some update webinars starting in September, so we will look forward to seeing you all then. Thanks to all, and we'll sign off for now. Bye.